Hello, everyone. Today's topic is palliative care for HIV patients. This is a diagrammatic uh, picture for the HIV virus. As you see, it's an RNA virus. It's a retrovirus. It got an envelope. It got a capsid. It got enzymes. It got glycoproteins. Objectives of this presentation is to go through the history, define what is meant by people living with HIV, the symptom burden, medications, acute HIV infection, the immune reconstitution syndrome, chronic comorbidities, prognostication, and end-of-life care. These are some celebrities that has HIV. The most important one, as far as I'm concerned, is this gentleman in the middle. His name is Magic Johnson or Michael Johnson. And he's a famous basketball player. And he did a lot of contribution in the research of HIV and treatments. Global estimates by WHO region, there is at least 36.7 million people living with HIV globally. In Africa alone, there is 25.6 million. In the Americas, 3.3 million. Southeast Asia, 3.5. Europe, 2.4. Eastern Mediterranean, 360,000. Western Pacific, 1.5 million. So as you can see, Africa is, basically the continent that has the most HIV infections in the world. History of HIV. The fields of HIV medicine and palliative care have both been dramatic changes over the past 40 years. Prior to 96, when the era of highly active antiretroviral therapy, the HAART, began, care for patients with AIDS consisted of symptom management and support, while patients rapidly declined and died. As HIV infection became a chronic disease rather than a rapidly fatal one, the widespread dissemination of HAART in the developed countries led to precipitous decline in mortality for HIV-infected patients. So basically, HIV is, history has been changed after the discovery of these antiretroviral therapies. HIV became a chronic disease. So patients will have almost like a normal lifespan, but with a chronic disease. As long as they're taking their medication, they can still function. But unfortunately, still, these patients suffer from a lot of psychosocial comorbidities. As a result, the number of people living with HIV, we call them the PLWH, for long periods has increased dramatically. As a consequence of aging, comorbidity has become increasingly common among PLWH. This includes a rapid increase in non-AIDS malignancies, which are now the leading cause of death. This is very important. All right. There is a rapid increase in non-AIDS malignancies, which are the leading cause of death right now. Multimorbidity among people living with HIV, largely cardiovascular disease is increasing as well. All right, uh, with prevalence and outcomes both worse than general population. And there is a reason beyond this because, a lot of these antiretroviral medications has some cardiovascular adverse effects. How does an HIV attacks? An HIV is a retrovirus, as we mentioned, meaning it stores the genetic material as RNA or ribonucleic acid. It attacks the immune system by invading the white blood cells, known as the CD4 cells. The virus builds DNA inside the host cell, and then the virus DNA combines with the host cell DNA. Following this, the DNA of the infected cell now produces new virus RNA and proteins. Developing HIV push out of the cell and then break free, and the CD4 T cell dies off. Working virus mature from raw materials circulating in blood, find more CD4 cells to attack. AIDS occur when CD4 T cell count falls below 200 millimeter cube per millimeter cube. Most common methods of transmission of HIV are unprotected sex, sharing needles with infected persons, transmission from an infected mother to fetus, infection from blood products. What are the stages of HIV? Acute HIV, chronic HIV, and then AIDS. Acute HIV is like a flu-like symptom that occur days to weeks after contracting HIV. And usually this phase is misdiagnosed as a regular viral infection. Chronic HIV, which is also known as latent or asymptomatic stage, can last for several years. Patients might have chronic HIV for a long time without being diagnosed. And the third phase is the AIDS. And this happens when the CD4 count falls below 200 cells per millimeter cube, making a person vulnerable to opportunistic infections and AIDS defining conditions. Symptom burden. More than 50% of deaths in HIV infected individuals are from non-AIDS conditions. The prevalence of comorbidities in HIV infected individuals depend on a number of factors, including age, health behaviors, CD4 count, and HIV treatment history. Life expectancy for those living with HIV is now near normal in both low and high economic countries. Many patients do not experience opportunistic infections for much of the duration of their disease. However, patients being treated for HIV infection in the outpatient setting still have high symptom burden, whether or not the disease is well controlled. And the most prevalent concern tends to be pain and psychological. So despite the low incidence of the opportunistic infections nowadays, especially if the patient is compliant with his medications. But still, these patients carry a high burden of psychosocial and pain issues. This gives you the diagnosis and deaths in thousands. And this years of diagnosis, as you can see, there is a drop at in 1993. of the number of deaths. Role of palliative care. Over the same time period, the field of palliative care has broadened as it became more apparent that patients with complex chronic diseases can benefit from palliative interventions throughout the course of the disease, not just at the very late stages. Early palliative care has been shown to prolong life in patients with cancer and to improve the quality of life in patients with chronic diseases. Evidence now exists that early integrated palliative care can improve outcomes for patients living with HIV, and that such a person centered approach can reduce stigma. Although HIV infection is no longer rapidly fatal, HIV infected patients continue to face significant stigma in both developing and developed countries. Systematic review findings showed that palliative care for patients living with HIV improves pain, symptom control, anxiety, insight, and spiritual well being. There is a high continuing prevalence of physical and psychological symptoms among patients living with HIV that are associated with poorer quality of life, suicidal ideation, poorer treatment adherence, treatment switching, sexual risk taking, uh, and viral rebound. The prevalence of depression and anxiety among patients living with HIV is higher uh, compared to other chronic conditions. HIV continues to largely affect key populations: men who have sex with men, sex workers, injecting drug users, racial minorities, and people in sub Saharan Africa. Stigma, discrimination, and poverty still mitigate against access to appropriate health care for these groups. The holistic approach. In the changing epidemiology of HIV, new challenges of aging with HIV, the principles of holistic, person centered care continue to be needed. Data from patients living with HIV is high in high income country identify persisting concerns across domains. Example, physical, pain and GI symptoms, cognitive, memory and sleep, psychological. Example, anxiety and depression, social, isolation and intimacy, welfare, finances, and fears regarding change of immigration status and information, long-term outcomes needs. Within low-income country, person-centered needs were identified as information on treatment options, involvement in decision-making, stigma, and poverty reduction, and focus on pain, symptoms, and psychological well-being. Patients report that routine outpatient HIV care does not adequately address mental health and social well-being. So in this slide, basically, we're comparing, the high income to low income countries and how they dealing with patients living with HIV. And we're trying in this model here to, adopt the holistic patient-centered care approach. Diagnosis of HIV. As you see, HIV-1 and 2 antigen antibody combination immune assay, and then either positive or negative. If it's positive, you have either HIV 1 positive or HIV-2 positive. And if it's negative, you know, for HIV-1 and 2, antibodies and P24 antigen, then you don't have HIV. Now here, you still, let's say you have positive for both viruses, okay, or negative to both viruses, or indeterminate. Then you do another test, which is called the NAT test, nucleic acid test, okay. So, and then this will, basically confirm whether you have HIV or not. So basically, you start with the antigen antibody combination immune assay. Let me put it this way. And if you're in doubt, you do what we call the NAT test or nucleic acid test. So we're going to talk about some of the medications here. Okay, so what is HAART or HAART? These are abbreviation for highly active antiretroviral therapy, and it consists of a minimum of 3 antiretroviral drugs. And basically, potent HAART regimen typically includes 2 NRTI medications plus 1 or 2 of the PIs or NNRTI. We're going to go through these in the rest of the presentation. Mechanism of action of antiretroviral drugs. We have different drugs. We have the protease inhibitors. These are referred to as PI. Integrase inhibitors, fusion inhibitor, NNRTI, and NRTI. So these are the 5 categories of antiretroviral medications. Okay. Another picture for, different drugs and, their, mechanism of action. For example, NRTI and NNRTI, which are basically the most important, group of drugs. They work on the reverse transcription here after the virus entry, while the PIs work on the proteolytic process of viral proteins. Again, medications for HIV. This is a very important topic. You should have a good picture of it, because you're gonna face, prescribing these medications at end of life. And if you're not aware about their mechanism of action and side effects, this might create some problems. So we'll talk about the NRTI. The NRTI is an abbreviation for nucleoside or nucleotide reverse transcriptase inhibitors. And these are just some examples of them, like didanosine and azidovudine, and so forth. And these are the side effects of these drugs: bone marrow suppression, myopathy, neuropathy, diarrhea, headache, lactic acidosis, and pancreatitis. So, a wide variety of side effects. And then you have the NNRTI, the non-nucleoside reverse transcriptase inhibitor, like efavirenz. And this might cause rash, dizziness, teratogenicity, and enzyme induction. How about the protease inhibitors? Can cause kidney stones, diarrhea, inhibition of enzymes, and elevated triglycerides. Integrase inhibitors can cause hepatotoxicity. Fusion inhibitors can cause headache and bacterial pneumonia. So usually when we treat HIV, we give two NRTIs, like these two, for example, tenofovir and abacavir. So when you do so, you have to add a third drug. And usually we add a third drug from a different class, such as NNRTI or PI or integrase transferase inhibitor, INSTI. Unfortunately, these drugs have a drug-to-drug interactions because they actually work on, they got metabolized by the CYP450, and they affect, these enzymes, um, either as an inhibitor or as an inducer. So be careful when you start a medication. You need to know its drug interactions. HIV also can cause HIV-associated dyslipidemia. And basically, it's fat accumulation, HIV lipohypertrophy, increased abdominal fat, dorsal cervical fat pad. So there is, like, in this condition, fat accumulation in basically in a certain distribution. It's not like the patient becomes more obese. It's just like, it changes the ways the fat is accumulated in your body. And you can see here, like in this picture, multiple facial shadows, sunken temples and cheeks, prominent muscles and bony landmarks. All of these because of the, redistribution of the fat. And also, it has some metabolic changes, like increased triglycerides, decreased LDL, decreased HDL, and insulin resistance. And as you remember, this happens mainly with the PIs, okay? Protease inhibitors. Post-exposure prophylaxis, recommended when there's exposure to mucous membranes or non-intact skin. So this slide is mainly for the physician, more or less. If you have an exposure to HIV patient, and this is the preferred regimen. Acute HIV infection occurs soon after infection, can be asymptomatic or subclinical. Fever, malaise, generalized lymphadenopathy, and maculopapular rash. Diagnosed by HIV-1, HIV-2 antigen antibody immune assay testing. Treated with the HAART. Patients are particularly infectious during this period. Main symptoms of acute HIV infection: pharyngitis, lymphadenopathy, muscular weakness. I mean, it's somewhat nonspecific, and it can be confused with other viral infections until you do the HIV test. Immune reconstitution, inflammatory response, or IRIS. Patients with opportunistic infections at the initiation of the therapy are at the risk of developing immune reconstitution inflammatory syndrome. So this happens as a result of initiation of the antiretroviral medication. Okay? Um, IRIS can occur in 25% of patients with mycobacterial, fungal, or viral opportunistic infection and may worsen symptoms of a known opportunistic infection or unmask a previously recognized opportunistic infection. IRIS occurs most commonly in the setting of Mycobacterium avium complex, TB, and cryptococcal infections. IRIS should be suspected if there is a worsening of symptoms of an opportunistic infection that was previously improving with effective treatment and if there is an evidence of effectiveness of the HAART, including a rise in the CD4 count or a decrease in the HIV load. The symptom burden of IRIS depends on the severity and the nature of the underlying opportunistic infection. Neurological, pulmonary, dermatological symptoms are common. If IRIS is not recognized and measured aggressively, it could be fatal. So, in a nutshell, the IRIS or immune reconstitution inflammatory syndrome is an inflammatory response to the initiation of the antiretroviral drugs in patients that has opportunistic infections. And it should be treated aggressively with steroids and non-steroids because it's an inflammatory response. IRIS may persist for months and in many patients. Therefore, adverse effects of corticosteroid use can be expected. Pain is common in patients with IRIS and should be treated with analgesics, including opiates in severe cases. Opportunistic infections depends on the CD4 count. So if the CD4 count is above 500, you get community-acquired organisms. If it's between 200 and 500, you might be attacked with something like TB. Less than 200, you get the Pneumocystis jirovecii or Cryptosporidium candida fungal pneumonia. Less than 200, toxoplasmosis candida. Less than 50, CMV, Cryptococcus, Mycobacterium avium complex, and CNS lymphoma. Kaposi sarcoma. It's an HIV-associated Kaposi sarcoma, 95% in homosexual or bisexual men. Etiology, genetic marker, immune dysregulation, retroviral, HHV8, human herpes virus 8. All of these are etiologic factors for the Kaposi sarcoma. Symptoms and signs of respiratory and GI involvement. In the classic form, they develop in the lower extremities. Cutaneous lesions may progress through 3 stages: macular stage, plaque stage, and tumor stage. Cryptosporidosis, and basically, this could be related to contamination of water and foods, and also can happen in patients with HIV or AIDS. Pneumocystis jirovecii pneumonia, PCP, can present with shortness of breath, cough, fever, signs like tachypnea, tachycardia, cyanosis, lung auscultation, often normal. Esophageal candidiasis. This one can lead to difficulty swallowing, what we call odynophagia, and the results in inadequate oral intake, such as dehydration, malnutrition, and wasting. And the treatment basically is fluconazole, 200 milligram, then 100 milligram daily for 14 days. Toxoplasmosis, and this typically occurs at the CD4 less than 100. And this affects the brain and can cause headache and confusion. Cryptococcal meningitis is another opportunistic infection. And the causative agent is Cryptococcus neoformans. Mycobacterium avium intracellulare, or MAC, most common non-tuberculous mycobacterial infection associated with AIDS. And it can show up as fever, swollen lymph nodes, diarrhea, fatigue, weight loss, and shortness of breath. Cytomegalovirus. Asymptomatic persons with CMV infection excrete the virus in saliva, respiratory secretions, urine, and semen. Clinically significant CMV infection is associated with CD4 less than 50. CMV-associated syndromes most commonly seen in patients with AIDS are retinitis and enteritis. So it affects the eye and the GI. Prophylaxis of opportunistic infections in HIV. Pneumocystitis usually occurs in CD4 less than 200, and these are the medication we use, like dapsone, for example. Toxoplasmosis usually happens with the CD4 less than 100, and in this situation, we use cotrimoxazole. Also in pneumocystitis, we use cotrimoxazole as a first line and dapsone as a second line. With toxoplasmosis, cotrimoxazole as a first line and pyrimethamine or dapsone as a second line. CMV, we use, and this, as we said, happens in CD4 less than 50. So in really highly immune compromised patients. And in this situation, we use again cyclovir, which is an antiviral medication. Tuberculosis, we start with rifampicin and isoniazid. The MAI, other words, Mycobacterium avium intracellulare. And this happens also at CD4 less than 50. And the first line is azithromycin. So as you can see, I mean, it's simple. You look up the CD4 count, and then you will figure out which drug to prophylax the patient with. HIV and pain. So the commonest two problems in HIV is distal sensory polyneuropathy. And then we have antiretroviral toxic neuropathy. So basically, distal sensory polyneuropathy is secondary to HIV, and the antiretroviral toxic neuropathy is secondary to antiretroviral medications. So these are the common risk factors for neuropathy in HIV patients. Advanced disease, CD4 less than 100, viral load more than 10,000, history of neuropathies, use of neurotoxic drugs, nutritional deficiency, history of TB, diabetes, aging with decreased neurologic function, hypertriglyceridemia, hepatitis C, and excessive alcohol abuse. As you can see, this is the distal symmetric polyneuropathy compared to other ones like inflammatory demyelinating or progressive polyradiculopathy. So this is the picture that you see with HIV patients, the distal symmetric polyneuropathy, the first one in the left here in the picture. Okay, we'll talk a little bit about spectrum of HIV complications. As you can see, it can affect almost every organ in the body. So the top HIV comorbidities are accelerated aging, cardiovascular, pulmonary, renal, hepatic, non-AIDS defining malignancy, substance abuse, malnutrition, psychological, and polypharmacy. Cardiovascular comorbidities. We'll start with the cardiovascular disease. Cardiovascular disease is prevalent in HIV-infected population due to normal aging, established risk factors such as smoking, hypertension, and disease-specific risk. HIV infection is also a pro-inflammatory state that leads to increased risk of cardiovascular disease, and controlling HIV infection may be an important risk-modifying intervention. One of the HIV antiretroviral medications, abacavir use, increases the risk of cardiovascular events, most likely through a pro-inflammatory mechanism. For example, statin use may be associated with increased risk of peripheral neuropathy in HIV-infected individuals, and this may have an important implications for adherence. Pulmonary comorbidities. In addition to opportunistic lung infections such as pneumocystis jirovecii, pneumonia, or bacterial pneumonia and TB, can cause respiratory disease in patients with higher CD4 counts while on HAART. HIV infection in both pre and post HAART eras also poses an independent risk for development of COPD and emphysema. HIV-infected individuals have higher rates of smoking, and the deleterious effects of smoking appear to be synergistic with HIV disease itself, causing even greater mortality and morbidity in smokers with HIV compared to smokers without HIV. Renal comorbidities. HIV infection is linked to renal disease, particularly in African American patients, through an unknown mechanism. In the pre-HAART era, HIV-associated nephropathy, HIV-associated immune complex kidney disease, and thrombotic microangiopathy were common. In the HAART era, treatment-related nephrotoxicities, particularly from the use of tenofovir and imidazole, has become an issue. There is evidence that even in the HAART era, the risk of renal disease persists. The risk of progressing to chronic renal disease over time is similar in HIV-infected patients to patients with diabetes. Lessons learned from the experiences of palliative providers can assist in open and sensitive discussion about when to initiate and stop hemodialysis. Hepatic comorbidities. HIV-infected adults commonly have common liver disease, partly because of high rates of hepatitis C in the population of IV drug users in developed countries and higher rates of heavy alcohol use in HIV infected population. AIDS may be associated with a number of biliary tract abnormalities. Patients with advanced HIV may develop acalculous cholecystitis, focal distal biliary stenosis at the ampulla of Vater, or multifocal stenosis of the biliary tree that resembles primary biliary cirrhosis. Diarrhea in AIDS, usually related to multiple pathogens. The most important ones are Cryptosporidium. Remember, we talked about it shortly in the early part of the presentation. And also Isospora, especially in a CD4 count less than 200. Salmonella has a high risk of bacteremia. And then you need to consider strongyloides in immune-compromised patients that have strongyloides is basically, a kind of a parasite that will show up with zoonophilia, polymicrobial sepsis, and meningitis. Long-term survivals of HIV have high prevalence of diarrhea, according to the study. HIV-associated wasting, involuntary weight loss of more than 10% of baseline, plus chronic diarrhea, more than 2 loose stools for more than 30 days, or chronic weakness associated with enigmatic fever, more than 30 days. Malignancy comorbidities. The heart era has changed the spectrum of malignancy in patients living with HIV. Although AIDS-defining cancers such as Kaposi and non-Hodgkin lymphoma remain important, many patients are now also developing cancers not traditionally associated with AIDS, such as lung cancer, skin cancer, hepatocellular, Hodgkin, human papillomaviral cancers, such as anal or penile cancer. Although patients living with HIV are current or former smokers, HIV infection itself seems to act synergistically to elevate the risk of lung cancer. Anal cancer is particularly prevalent in patients living with HIV and can present specific challenges to patients and clinicians. Anal cancer tends to be very painful and to require high-level symptom management. Particularly as the disease progresses, pain can be related to both tumor burden and to radiation therapy for the disease. AIDS-defining cancers such as non-Hodgkin, Kaposi, cervical cancer, non-AIDS defining such as lung cancer, breast cancer, colorectal cancer, and prostate cancer. AIDS dementia complex. Approximately 2/3 of patients with AIDS develop dementia, mostly due to AIDS dementia complex. In some patients, HIV is found in the CNS post-mortem. In others, an immune mechanism or an unidentified pathogen is blamed. Dementia is initially of a subcortical type. Treatment is AZT or zidofudine. Psychological comorbidities. In developed nations, injection drugs using remains of drug use remains an important risk factor for contracting HIV. Continued misuse of opioids can place patients at a greater risk for hepatitis B and C co-infection, hypogonadism, osteoporosis, malnutrition, and decreased physical activity. Substance abuse is also linked to poor adherence to the heart and greater mortality. In addition, substance use, other psychiatric conditions are among the most common comorbidities in population of patients living with HIV, with the prevalence of anxiety and depression almost 50% of the time. HIV and pregnancy. The hearts are recommended for all pregnant women. The only drug contraindicated is efavirenz. If viral load less than 100, vaginal delivery is acceptable. Baby should be on a heart if mom viral load is more than 1,000. Zidovudine is acceptable. Breastfeeding is contraindicated. Events in care screening questionnaire. This questionnaire was designed to identify the needs and concerns of people living with HIV or AIDS in 9 specific domains. Prognostication. The most important prognostic factors is age, CD4 count, HIV RNA copies, CDC disease stage, and HIV transmission through injection drug use. And there is a calculator you can use from the internet that you can gather this information and gives you the prognostication. The CDC classified HIV according to the CD4 cell count and also whether the patient has, clinically the acute HIV infection or patient symptomatic or has AIDS indicator condition. And accordingly, they put it in a table here, A1, A2, A3, B1, 2, and 3. And this, you can actually, for example, you have a CD4 count of more than 500, and you can have a symptomatic case. This will be called B1. And as you see from the picture here, as the viral load goes up, the CD4 count goes down. There is an inverse relation between the viral load and the CD4 count. So the more the viral load, the less the CD4 count, the worse the prognosis, and you're approaching, AIDS and eventually opportunistic diseases and death. And that's why in the prognostication, we have the CD4 count and the HIV RNA copies. All right? And then we had remember the age, CD4 stage, disease stage, and the HIV route of transmission. 5 factors affect the HIV prognostication. Prognostication in HIV was traditionally related to the markers of HIV. However, given that many HIV-infected individuals will die of other causes, a broader approach to prognostication near the end of life is needed. So the 5 factors I gave you, these are the traditional prognostic factors. However, because nowadays with the treatment, HIV patients die from other different things, then we need a different prognostication scales. One of them is called Veterans Aging Cohort Study Risk Index. Okay, end of life. and palliative and in HIV patients. If a patient's life expectancy is limited to be weeks to months from comorbid cancer, cardiovascular, pulmonary, liver, or renal disease, clinicians must weigh the benefit and burdens of continuing the HAART carefully. So this is one of the main questions at end of life. Shall we stop or shall we? Shall we continue the medications? All right. Now, there are benefits and burdens of doing this. I want to say that patients or the clinicians should remain aware of something called the Lazarus effects. And these are the patients who appear to be imminently dying from AIDS related causes, who have not received an adequate trial of the HAART. Initiating antiretroviral may cause a rapid reversal of the disease process, allowing them years of additional life. So this is one benefit of trying the HAART in patients that did not have adequate treatment for whatever reason. Could be the patient was not adhering to the medication regimen, for example, or the medication was not available for in some developing countries. So that's why it's a controversial thing. So we have benefits and we have burdens of stopping the HAART. So benefits prevention of a retroviral syndrome. Also, a treatment of the syndromes or symptoms affected by viral load or viral fitness. The severity of the HIV-related neuropathy and constitutional symptoms such as fatigue, weight loss, correlate directly to the viral load. So if I stop the HAART, I might start to have more of these, HIV-related, comorbidities, such as the neuropathy or weight loss or fatigue, because it's directly related to viral load. Also, keeping the HAART medications might prevent opportunistic infections, because the HAART reduces the incidence of opportunistic infections. And we talked about the Lazarus effect. Delay the progression of AIDS dementia complex. Hope for positive treatment effect. Okay, so as we mentioned here, the Lazarus effect. Especially in patients that did not have an adequate, therapy for HIV. How about the burdens, the cost? Okay, it's pretty costly, and also the side effects. The HAART is not benign. I mean, they have GI complications, headache, fatigue. Didenosine may precipitate gout and pancreatitis. Zidovudine might precipitate something like myopathy. Zalcitabine, peripheral neuropathy, stomatitis and arthralgia, efavirenz, and lamivudine, depression and anxiety. Pill burden. In the study, male veterans with a variety of chronic medical problems, perception of over-medication was associated with decreased quality of life. Okay, key learning points of this presentation. The reintroduction of palliative care as a part of HIV treatment and care provision can be achieved. First, palliative care should be integrated appropriately for patients living with HIV according to the needs, not prognosis. Early integration of palliative care is highly relevant for a wide range of progressive and incurable comorbidities seen among patients living with HIV. Second, early identification of preferences and advanced care plans should enable Professionals support patients where there is a clinical uncertainty. Third, HIV specific palliative care services may not be necessary if good teamwork between HIV physicians and palliative care teams can determine optimal treatment plans while minimizing polypharmacy. This requires continuing professional education programs for HIV clinical teams to include palliative and end of life care. I just want to end here by um, explaining my own personal experience with these patients. Usually, these patients were referred to us for symptom management, and usually um, we take care of their pain, different psychosocial issues, and so forth. And usually, the ID or infectious disease doctor will be taking care of the HIV medications. Okay, and as I said, it's important to integrate early on because especially when the patient reaches the end of life, the patient already knows you very well, and you can make a smooth transition. When you take over at the end of life, and then you can start to explain to the patient why we're gonna, stop or not stop the medication, whatever, the discussions will be. It will be much easier to be done. Um, as a palliative care doctor, you should be aware about, HIV medications, different HIV comorbidities, because this will affect your, palliative modalities that you're going to be giving to your patients. Thank you so much.